Great. So I think I'm going to start and folks will join us as they can. But I'm really excited to introduce for the next 2 hours a panel that's going to be focused on US born Latinos and immigrants, the Latino community. And we're really excited because we're going to do two things. And we're hoping to actually set the stage by providing some context, particularly as it pertains to the US and Mexico and Latin America. And we asked a really eminent expert, Dr. Andrew Seeley, who specializes in all things US, Mexico, and Latin America, to sort of set the stage for us outside of the HIV context, but help to prepare what's going to follow. What will follow is a discussion that is focused on the local experience and providing prevention and treatment to people here in Texas around HIV in the Latino community. But we wanted to start first with you, Dr. Seeley. And so I'm just going to say a couple of words and welcome you officially to PACHA. Appreciate you taking the time. I know that you're in Mexico City right now, or Mexico at least, and we're very thankful for your being here today. So first, just as a way of introduction, Dr. Andrew Seeley is the president of the Migration Policy Institute, MPI, which is a global nonpartisan institution that seeks to improve immigration and integration policies through fact-based research. That's actually something I want to emphasize, fact-based research. Your own research, Dr. Seeley, focuses on migration globally. You have written numerous books, I think most recently, Vanishing Frontiers, Forces that are Driving Mexico and the United States Together. You've also published opinion pieces in really prominent publications, including Foreign Affairs, Foreign Policy, America's Quarterly. You're a regular contributor to Mexico's largest newspaper, El Universal, and you lecture at Hopkins, at George Washington, as well as the prestigious El Colegio de Mexico. Prior to joining MPI, you spent 17 years at the Woodrow Wilson Center, where you founded the center's Mexico Institute, and later served in a number of administrative roles. We are delighted to have you here, and thank you again for taking time from your busy schedule. Welcome.
It's great to be with you. Good to see you again.
Good to see you as well. So Dr. Seeley, Andrew, if I may, we were hoping that we could maybe have a bit of a conversation that sets the stage for what will follow, which is a panel that would be more focused on Latinos and HIV prevention and treatment. But recently, I heard you lecture in Mexico City around the importance of US, Mexico, and Latin America relations. And I thought you had a pretty unique perspective and was hoping that you could probably help us to understand, why is the relationship between Mexico and the US so important?
Well, thank you, Vincent. And first of all, to everyone there, I mean, I am the least expert person in this room, assuming I'm virtually in the room with you on HIV/AIDS, but just enormous appreciation for everything that you're doing, and thank you for letting me be a small part of this really important effort. It's a unique relationship, right? The U.S. doesn't have any other relationship quite like this. Canada is the closest we get, perhaps, as a neighboring country. But with Mexico, Mexico is now our largest trading partner. It is the country that is the country of heritage of more than a tenth of our population. Certainly not all Latinos are Mexican descent, but about 2/3 are. So it is an important part. And technically there probably are more people who claim German ancestry out there, but that's usually pretty distant. Mexican ancestry tends to be, within 1 or 2 or 3 generations. So it is very much part of our present. We're deeply tied in. You're in Houston, and Houston is, the border starts there, right? I mean, the border doesn't start at the border. The border starts in the region. I would even say, higher up, perhaps, in Dallas and higher. The border starts there and goes pretty far into Mexico. People move back and forth continuously in ways that they don't other places. And by the way, not only is our largest sort of recent population, and certainly our largest immigrant population by far from Mexico, but the largest immigrant population in Mexico are Americans, where there are about 1 million, somewhere between, we don't exactly know, between 800,000 and close to 2 million people born in the U.S. living, and it's as many Americans as live in all of Europe. It is an enormous community. So there's just ties that we don't have with any other country in the same way, but it's also an unequal relationship, and we can get back to that. But it is a relationship between a very developed country, and the world's largest economy, with a country that has been coming up and is economically, much better off than it used to be, but still is a developing economy in many ways. And so it's also a complex relationship because of those dynamics.
Andrew, can you say something about the future of the economic well-being of the United States and some of what I heard you discuss around the regional importance of Canada, Mexico, and the US, and why we should care about that as a nation, particularly as it pertains to our well-being, health, and beyond that?
Yeah, I mean, look, I mean, first of all, I mean, obviously the demographic side is important, right? So many Americans are of Mexican descent, and you start to add in people, who are married to Mexicans, children of Mexicans, sister-in-law, brother-in-law of Mex, I mean, that, the ties are really deep between the two countries, and it is in Mexico. I mean, that, I always say there's no one in the U.S. who does not know a Mexican, and there's almost no one in Mexico who does not have someone in the United States, right? Rich or poor doesn't matter, right? That those connections are there. But also economically, I mean, Mexico has displaced both China and Canada as our leading trading partner. But not only is it a key relationship in terms of trade, but actually there's a lot of joint manufacturing. So there's a lot of things like airplanes and cars. It'd be almost impossible to get into a car today in the United States that wasn't at least partially built in Mexico. But also hard to get a car in Mexico that wasn't partly built in the US. And in Canada, by the way, most of them as well have parts from all three countries. They may have been assembled in Mexico, but they were probably part of it was designed in each of the three countries and pieces came from each. And in terms of public health, I mean, there's also an informational space. So I think two things. One is obviously the close family relationship, the large number of people who are immigrants from Mexico and the United States, which is, understanding that context, that history, those relationships. But also there's a huge informational space between Mexico and the United States. I mean, we should assume Univision, the largest, Spanish language broadcaster in the United States, is now, tied to Televisa, the largest, broadcaster in Mexico. They have a partnership through which they do joint content. I mean, increases an informational space between the two countries that also affects how you think of getting messages to people, public policy, and what sort of information people absorb.
Thank you.
And actually, let me throw into there one more thing, Vincent, just because
Sure.
it's fun, but it also matters, I think, for this, which is how connected. This is what I have a whole chapter in the book on Vanishing Frontiers on film, which was fun to write because so many Mexican filmmakers are making films in Hollywood and American filmmakers are making films in Mexico. But the serious point there is, I mean, that's sort of great in terms of culture. The 5 Oscar winners from Mexico and for Best Director, all those great things. But the serious point is there really is an informational space that crosses across the border, right? And there is a power of the messages. It's hard to think, we assume people get to the U.S. and suddenly their informational space is what they're hearing in the U.S., but people still consume information actually from Mexico and vice versa for Americans who go to Mexico.
Thank you. So Andrew, no, this is not new information to you, but I want to ask you about it in your perspective. So there's been a very troubling sort of increase in anti-immigrant, particularly anti-Latino sentiment in the U.S. Can you share perspectives on the origins? And so much of the narrative has been about the border, which is critical and important, but the Latino community in the U.S. is broader than what's happening with the border. And I think those things have been conflated in terms of our visibility as a community. What are your thoughts?
Right. Let me start with the Francis Key Bridge, which collapsed yesterday in really unfortunate circumstances in Baltimore. 8 people fell into the water, 6 of them lost their lives. All of them were Latin American immigrants. All of them were from Mexico and Central America. They were from Mexico, Guatemala, Honduras, El Salvador, the ones that I know about. But apparently all 8 were actually Latin American immigrants. And Baltimore is nowhere near the border, right? Right now you're near the border in Houston, but I mean, Baltimore is nowhere near the border. The Latin American immigrants are everywhere. The Latino community is certainly everywhere, but increasingly that is a result of the places that were traditional destinations for Latin American immigrants are no longer the only places out there. There is no state in the United States that does not have a significant Latino community. Remember, by the way, Bruno, if you want to say Hawaii, remember Bruno Mars, by the way, who's, part Puerto Rican. But I mean, there is no place in the United States. Latinos are everywhere, and certainly Latin American immigrants are everywhere. That's because of the shifting nature of jobs, right? I mean, the large number of immigrants, but also the shifting nature of jobs that attracted people to the Midwest and the South and places where you didn't have large immigrant communities from Latin America before. And certainly in places like Baltimore and Washington, D.C. So, but we are seeing a rise, partially because of that. We are seeing a pushback against immigrants. It is not in the traditional gateways, right? I mean, you don't see a lot of hate incidents in places like Los Angeles or Chicago. You see them in places that immigrants are newer, where they are beginning to change the cultural tapestry, where there's, a sense of threat, perhaps because some jobs have been lost along the way. Studies tell us it's not because of immigrants, by the way, but people often don't realize that. I mean, they see a world changing around them, of which immigration is a piece of which people speaking Spanish, they come into their communities and look different, is a piece of it, and you begin to see in the places where traditionally you didn't have as much immigration, as the real pushback is happening. And you and I talked about this a bit. I mean, there's a bit of this going on in Mexico as well, too, right? I mean, it's certainly much more in the United States. But there is a bit of this going on in Mexico against Central Americans, Cubans, Haitians, others. It's not nearly as salient an issue in Mexico, but as the numbers of people going through Mexico has risen, you do begin to see some incidents of pushback against immigrants from other countries, and distinctions that would seem laughable in the United States, right? I mean, we tend to think of a large Latin American community. Even Latinos tend to often, think of sort of a broader community. But in Mexico, you begin to see a pushback of Mexicans against Central Americans and others who are not as familiar, because this is still new.
Yes. So, Andrew, I'm curious about how organizations like PACHA and HIV service providers, how do we draw large Latino organizations to partner on ending HIV and other health inequities, who don't center themselves around HIV? And that's one of the great things about your being here, that you represent a very important institution, but not planted in the HIV space.
The good news on this is, this is really the immigrants in the United States, and Latin American immigrants in particular, are very well organized, but not always organized in a sort of coherent national way, right? I mean, there certainly are great organizations like Unidos US, which Vincent, well, and are part of the board, but that do represent a broad swath of Latinos, immigrant and non-immigrant, in the United States. But there are many among immigrants themselves, which is usually the harder to reach population, right? For many organizations, there's a real tapestry of hometown associations, federations, groups that are built around language, to the extent that also many Latin American immigrants are not Spanish speakers, right? There are many that are indigenous, or Garifuna, which is an Afro-Indigenous community out of Central America, but lots of indigenous groups out of southern Mexico, Guatemala, parts of Honduras, certainly Bolivia and Peru, and often tend to then be more organized around language than around location. But there really is a very rich tapestry. Many of the Latino organizations, the traditional Latino organizations, like those affiliated with Unidos and other big national organizations, do have access to these newer immigrant organizations, but they are often separate, right? This is true historically in the United States, right? People come to this country and, they start off in organizations that are, of people like them, from the same place, same language, same customs, often very local, and over time move into sort of more mainstream organizations, or they build those up into national organizations. But right now, among immigrants particularly, you have really a wealth of kinds of local organizations. So I think one of the opportunities, particularly HIV/AIDS, is, how do you get beyond the big national organizations and the known organizations to that next level out there of organizations that are, really quite active in the community and have credibility with people, and have credibility with the message. They're, the extent that credibility of the messenger matters really matter a lot. And some of them are grouped together. Guatemalans have recently tried to build a federation among organizations. There are some federations, usually statewide, of sort of Mexican states, that bring together a lot of the smaller Mexican organizations. The Salvadorans have tended to be very connected. There's lots of connections, but sometimes there has to be a little bit of groundwork to figure out who represents who, and who may not be as well known, but really does have credibility with key groups that you might want to reach.
Thank you. So, Andrew, final question. I wonder if you have any thoughts about sort of U.S.-born Latinos and relationships between, immigrants sort of immigrants that have been here for a long time and that remain undocumented but have been part of the country, and those that are immigrants and are documented, and then also new arrivals. This sort of group, this mosaic of different Latino segments. What are your thoughts about us coming together and better leveraging our importance for the future of the U.S. and for the region?
I think it's going to happen over time. It's going to happen in English, by the way, too. I think in reality, right? I mean, I think the tendency is, I remember having it, I hope no one from Univision is there that I don't want to offend, but I actually published this. So if I was going to offend anyone, I guess I have already. But I interviewed one of the anchors of Univision a while back, and, he said to me, one of the challenges for a Spanish language news station is over time, we're going to have more and more of an audience because there are more and more Latinos, but they're going to speak less and less Spanish. And to the extent they speak Spanish, it will be the second language, right? I mean, they may hold on to it for cultural association and to be able to talk to grandma, but in the end, English will be the language for consuming information. So I think we're going to see, this is a really significant, it's 18% right now of the US population is of Latin American descent, but it is enormously varied population, right? It includes people who go back generations and generations, right? For whom Latin America is, a cultural reference point, but it's not really part of growing up to people who arrived yesterday. And in between, there's all sorts of gradations. And then as you referenced, there's also people who, are citizens. The majority of Latinos are US citizens and they're US born, and people who've been naturalized. It's the vast majority. Then you have people who are residents, and then you have people who are completely undocumented. But in between, there's also a bunch of intermediary statuses. There's people who have DACA. There's people who have temporary protected status. There's people with humanitarian parole. There's lots of different people who are applying for asylum and they have permission to stay in the country and work, but they don't have any permanence behind that. And so it's an immensely varied population. And you add to that the cultural differences, some of the linguistic diversity for people who Spanish is not their first language, the national differences, the local differences in their countries, for among immigrant groups. It's a very varied population, but I do think the future, and Vince, I think your hint is, the future is there's going to be, everyone will keep a part of that diversity, right? Every group in the United States, there's enormous tapestry within what we define sort of as these broad groups in the United States. But I do think there is a growing number of people who see themselves as Latino rather than as, Mexican or from a particular town in Mexico, right? That sort of starts off, you're really from San Andres, and then over time you're Mexican, and then over time you're actually, Latin American immigrant, and then you're Latino, right? And I think that's the direction of the future. And it's not going to be a cohesive group in the way that no group in American society, that's many millions of people is cohesive, but I think there will be a common identity around that going forward.
Thank you. Andrew, thank you so much for being here. Again, appreciate your time. I realize that you're in Mexico. I think it's your vacation, so we greatly appreciate your taking the time to be with us. Just before we say goodbye, I just want to make sure...
Can't say no to Vincent, though. Yes.
Well, thank you. I want to give you just a chance to sort of crystallize if there's one or two things that you'd like us to remember as we move forward in our discussions about the Latino community in the U.S. and HIV prevention and treatment. What would those sort of words of wisdom be?
I think only one thing, which is I think don't forget, we tend to think of this within, there's such a huge array of organizations doing incredible work in the United States on HIV/AIDS. It's such a broad network to begin with, but don't forget the people on the Mexican side of the border, people in Central America and South America and in Haiti. My sense is, because people move back and forth so much, and I know many of you, in the room do have relationships with organizations that are working on this issue and with government agencies that are doing work on HIV/AIDS in other countries as well. But I think it's important to think transnationally, right? People, develop their knowledge base before they get here if they're immigrants, and many people go back, right? And so, I think beginning to think transnationally in a world and in a hemisphere where people move back and forth so much is a real opportunity, and it's a challenge logistically too.
Thank you, Andrew. It was really great having you here today. And just a round of applause for Dr. Andrew Seeley. Thank you.
Thank you. Thank you, everyone.
So with that, it's my pleasure to turn over the floor to Duvia and Guillermo, who are going to lead us in a panel that's specifically focused on U.S. Latinos.
Thank you, Vincent. And I really want to recognize that we're in Texas, and I think it's the proper thing to have this discussion. And obviously, it's about ending the epidemic in Texas, but also context matters. I think someone in the previous panel addressed that if we don't understand the context, it's hard to really address the issue at hand. As PACHA, we have the responsibility to look the whole picture of the United States and the territories, and obviously in this case, this panel about Texas, as I was saying, about the end of the epidemic. But before that, I want to take a couple of minutes, and my co-facilitator and amazing Dubia will do the same, and then we will proceed to have the panel, and then a Q&A, and we will be disciplined on those three elements. Very briefly, I think the difficult news that I want to just remind also is that we used to be the third most impacted. Now we are the second most impacted, especially if you look the data of CDC as 2021. And even though we are 18-19% of the US population, we are right now at 29% of all new infections. And also we represent 25% of all people living with HIV and AIDS in the United States. And that is, I think, a red flag for all of us that we need to go back and see what's the balance between care and prevention. To me, that's the structural question that we need to address, because we will never reach the 2030 goals if we have a profound disparity between care and prevention in the bottom. When we're dealing with in a condition that we know that is 100% preventable, but also we know the way that to reach U equal U is to have everybody in a viral load suppression to advance and avoid new infections. I also want to remind you the issues that the previous speaker was sharing with all of us, and I think it's key, the question of look things from a transnational perspective. The way that I will break it down to all of us, when we talk about Hispanic, Latinx, we need to deal with foreign-born and US-born Latinos and Latinas and Latinx. And I think that's a tremendous pressure for all of us that are focused on trying to reach, engage, 63, 64 million folks that identify as Hispanic, Latinx, with the background of coming from different countries. I always remember a campaign that was aiming to reach Central Americans, but it was with mostly Puerto Ricans and Dominicans. It will not, it's like, you know, having dinner during breakfast sometimes doesn't go. You need breakfast in the morning. And I always told people are the challenges for us to acknowledge. I will also add to all of you that the folks that are here in the US, Hispanic and Latinx, and Dr. Seeley was reminding us, we also send a lot of money back to our countries of origin. Let me give you one important fact. Mexicans in 2023 sent back to Mexico $64 billion. $64 billion. Salvadorians sent $10 billion. Guatemalans sent $8 billion. Dominicans send back $10 billion. What I'm trying to describe is when we talk about transnational issues, is also that I always told people, you know, and I remember with COVID, one key element was also to look what the media in those countries were broadcasting, because people consume media from their countries in the US and also back and forth. And finally, I want to tell you that the next month is going to be a very important conference in El Paso, Texas, May 2nd through the 4th. Many of us will be there. It's the National LatinX Conference on HIV, hepatitis, and substance use. It's a national prevention and training. It's a multi-issue conference. We're very proud that Valley Ace Council is one of the lead organizers of that. But also in May 6 and 7, we're going to be doing a health policy summit focus on Hispanic Latinx issues, because we truly believe that every 4 years, that May summit happens every 4 years, every time we have presidential elections, because it's important. If you're not in the table, you're a menu, part of the menu. And I think it's important to have that perspective. And also other regional meetings are coming up, one between California and Nevada in October. Natalie is very involved with that, along with Duvia. And also in October, we will be doing a regional Latinx gathering in Charlotte, focused mostly in the South. And by the way, the largest internal migration of Hispanics, guess what? Toward the South. Largest state that have been getting internal migration is Georgia, followed by North Carolina, and then Louisiana. And obviously, Texas and Florida, you know the story, is huge. With that, I pass the mic to my adorable co-facilitator, partner in crime for today's panel, Duvia.
Ooh, gracias for the adorable. Thank you so much. I am feeling adorable today. Buenas tardes. Good afternoon, everybody. I thought we would start with a little Spanish greeting, since this is a panel that is going to be focused on Latinos here in Texas. Some considerations for us to take before we start with our panelists is that Texas is among the U.S. states that is most affected by HIV, Houston being the largest city and the city with the highest rate of transmission amongst Latinx individuals, including immigrants. We all know that Texas is the state with the longest U.S.-Mexico border in the U.S., which is also something that impacts Latinx individuals, the increase that we're seeing in Latinx individuals living with an HIV diagnosis here in Texas. In Texas, 1 in 6 residents is an immigrant, and we know that HIV and STIs know no borders. There is still a lot of work for us to do in terms of, from a perspective of humanity and cultural humility, to end the HIV epidemic. And today we have invited our panel of experts to help us address the barriers and the struggles for basic needs such as healthcare, housing, education, workforce, Latinx individuals, for Latinx individuals living with an HIV diagnosis who may be uninsured, underinsured, or undocumented. Panelists, please remember that we have about 10 minutes for each one of you, and we will start with Dr. Daniel Castellanos, the Director of the Institute for Hispanic Latinx Health Equity and VP of Research and Innovations for the Latino Commission on AIDS. Dr. Castellanos, please take it away.
Thank you. Hi, how is everyone? Tired? I bet. And that's the reason why I decided to skip many of the slides. So what I want to say is that we have to look at the micro and the macro. And we have been talking a lot about how space is important, meaning the physical space where we live. Context is important. So we are going to take a look at a little bit about the macro, but more importantly, we are going to look at the macro, because the macro, there are many stories have been told today, and I will be a poor job trying to equate to those stories. Next, I have it here. So Texas, right? Beautiful. In December, we go swimming in South Padre Island. And 3 days later, we go to Lubbock and we play snowball fights. That's Texas. 40% of residents in Texas identify as Hispanic, and 1 in 5 Hispanics live in Texas. So I just want to say thank you to my team. We have Evelio Escamilla and Rosana Guzman here. They have been my partners in crime, crisscrossing Texas, visiting our partners. There are 9 counties there that we visited twice a year, driving thousands of miles, going across, up and down the mountains. So and the valleys and the plains. So this is Texas, right? Next one. It's me actually. so, so I just want to open with something from Healthy People's 1979, the first time that there was a Healthy People document highlighting the national needs in terms of health. And I want to open with Joseph Califano's words. I'm going to read them. And of course, there will be controversy about welfare, income maintenance programs, food stamps, and other efforts to alleviate poverty. But we simply can avoid the fact that if we are to mount a successful second public health revolution, we must deal effectively with deep social problems that destroy health. This is 1979. So history was going to judge us if we have lived up to those words. These are some of the slides that I skipped, so I'm going to give you just a quick summary, and it's the macro perspective. The need to recalibrate the 4 pillars. We need to look at context. We need to look at the geographic spaces, the public health infrastructure in those spaces. And I'm just going to give you a couple of data. You can find the printout outside. HIV and aging. New York County is already at 52% of people living with HIV 55 and above, 52%. El Paso County is at 34.8%. 34.8% of people living with HIV are 55 and above in El Paso. But in Hidalgo, it's 25. So that means that there has to be different ways of tailoring the 4 pillars to the local realities. We cannot just assume that a national strategy is going to work across the US, including Puerto Rico, the Virgin Islands, and other territories. And I just want to mention that Harris County is at 30%, and we are so happy that Harris County decided to use some money that was unspent to create HIV and aging medical case management in preparation for what we are going to be seeing in 5-10 years. So kudos to Harris County. But we also we need to support El Paso, where 34.9% are already 55 and above. So there is a lot of work to do about that. I want to mention something that Jesse said before about the HIV and aging and the donut created in terms of moving from private insurance to Medicaid and Medicare. There is going to be a big pothole when our clients from Ryan Y age become older or start getting early symptoms of aging at age 45 and 50, and they are not eligible for any Medicaid or Medicare. So who is going to pay for all these aging services? We will come back in a moment to what it means actually on the ground. In terms of the HIV continuum of care, it looks for a context. In New York County, 60% undetectable viral load, and this is data from 2021. And in Travis County, 69.7, closer to 70. And then you go to Webb County, 50%. So we have a lot of work to do. And then when you look at the HIV continuum of care, and you can see the chart in the printout, you are going to see that 4 of the 9 counties that we have partners in, 4 of the counties are on the border. And those 4 counties have the lowest percentage of undetectable viral load across the state. So that's where we are in terms of local context. So I skip a bunch. So now we go to systems of exposure. And I want to give kudos to Chatera over there, who was questioning the idea of social determinants of health. Because the social determinants of health tend to focus on labeling an individual as homeless or as lacking insurance. What we don't talk is about, as she was saying, at the systems that create those social determinants of health. And kudos to SAMHSA, who has been working on looking at how exposure to the criminal system, to the legal system, to the justice system, has impact on diabetes, on substance use, and you guess who are the most impacted? because of that exposure to a system. So I was so happy when you brought that up. And I think as someone, I remember this morning who said that we do the interventions and then someone give it a name to the intervention, because we have been experiencing that in the community. We know we were talking, even if we don't have the name for it. But here are some names. The idea of fundamental causes. Bruce Link and Joe Phelan, check it out, because it doesn't appear in the Healthy People 2030 or anything. Because these concept questions the structures, the systems that create those social determinants of health. Also, the idea of syndemic. And we talk a lot about syndemic, but as Paul was questioning this morning, what have we done about syndemic? So we can describe it, we can point it out, but what are some of the responses to that? A new concept that came out recently, and that's why I was excited when some people were mentioning it before, was the idea of systems of exposure. And again, kudos to SAMHSA because it's already looking at that. I'm going to give you some examples of that. We know for a long time that MTB and HIV are connected because some of the cases, because the connection between housing and exposure to tuberculosis and HIV and homelessness, etc. So we have known that. This is the risk factors in Texas in 2022 because there has been an increase on tuberculosis. But guess what? When you look at them, you are going to be looking at a lot of syndemics, right? You are going to be looking at, and I'm using the term syndemics in the strict sense that Meryl Singer created it, which is that biological connection between two diseases, right? So there you are going to see HIV and tuberculosis, for instance, right? The biological impact of substance use on treatment and the physiological impact as well, right? And this is where the MTB cases are. Remember I mentioned about all the cases of HIV along the border? That's where we are for tuberculosis as well. So I hope you are getting the sense now that we are talking about structures and systems. This is the percentage of uninsured by region in 2021. And as you can see, the 4 counties along the border have the largest number of people uninsured in Texas. 30% in Hidalgo County, 28% in Webb County. For the US, 8.6. So there is a system, the healthcare system that we have, the insurance system that we have, is creating exposure for some and not for others, depending on where you live. I'm not going to bother you with life expectancy, because if you live in certain counties, your life expectancy will be higher or lower. This is the percentage of households below the federal poverty level, which is already low, right? So figure it out. A quarter of people in Hidalgo County, poor, below household living below the federal poverty. And if you look again, there you have the 4 counties along the border: Hidalgo, Cameron, Webb, and El Paso. So we you know, Houston, we have an issue, right? Think about this. This is the shortage of the professional, health professionals in the Texas health system. And I just want to point out just a couple, just one community health worker for every 4,900 Texans. Think about one community health worker to work on HIV prevention, linkage to PrEP, and everything along the continuum on HIV, plus diabetes, plus cardiovascular disease, plus obesity. So that's what the system is. So we talk a lot about behavioral health. Let's see. One psychologist for every 6,000 Texans. One psychologist for every 6,000 Texans. And this is one of the ones I like the most. I don't know exactly right now where the bill is, but it has been in committee for about 4 or 5 years, I think, since 2019, I believe. And it's to enhance the health system within high schools. And there you have one social worker for every 6,626 students. One social worker for every 6,626 students. And in our conversations across the state, these social workers told us that most of the time they spend in administrative work, filling out paperwork. And I see some notes heading, so you know the story, right? So when we talk about behavioral health, and we wonder why young people are still contracting HIV, look no further. Workforce development is a key element of what we do and how we can address the HIV epidemic and the other ones, you know, the syndemics. These are the percentages of Hispanics in public health institutions in Texas obtaining degrees. And this is the latest data, 2022. And you can see the red line is because Hispanics represent 40% of Texans, albeit 15% of doctoral degrees. And I want to pay special attention to this because then when we have a workforce that is created in Lubbock, or let's say Amarillo, right? And then the person has to find a better job or even be promoted because a 5-year grant doesn't include raises, right? So then you move to Lubbock, and then you move to Fort Worth, and then perhaps you end up in Houston. So this is drainage, a geographic drainage, but also to the hospitals that can afford, that can pay high salaries. 2 more minutes. So quickly, takeaways. Oh, sorry, this is, so this is about leading the second revolution. So I'm going to skip and go straight to the revolution. Addressing the mechanisms. This is one of the things. How do we lead that? Addressing the mechanisms, like unequal service location, restricted eligibility, lack of Medicaid expansion, through which systems of exposure, the labor market, the justice system, immigration systems, create unequal access to flexible resources and disease exposure across Texas. Back to my friend who mentioned the systems early on. 2, how to provide flexible funding to recalibrate the ETE's pillars based on the social, cultural, and economic needs of the various counties in Texas. There has to be some flexibility between getting the grant and the next 5 years, the next cycle. Rebalancing the role and funding of CBOs and health organizations across Texas to provide culturally and linguistically appropriate services, address mistrust, and increase community-driven health promotion. We need some funding for promotoras. Someone was talking about 10,000 people. How we're going to train them? Well, we have to provide some funding for that. And how do we engage communities of faith in the work that we do? Because they're already doing the work. We just need to be synergistic about it. Addressing the Texas health workforce, we talk about, but it's not enough to train more people. I remember talking with Dr. Torres, the dean of the School of Social Work in Rio Grande Valley University. And he's like, yeah, but you know, we train doctoral students, and where are the positions in the universities for them? You know, where are the positions for them in research? And then something that is very important is integrating all the different systems. We talk about Medicaid and Medicare and the Ryan White services. But if we want to address this endemics, we have to start integrating those at the national level. These recommendations may sound Texas, but it's about West Virginia, Appalachia. It's about the plains of the South Carolina, you know, This is Alabama, this is Louisiana, this is upstate New York. We need to look at the systems that are creating those vulnerabilities across the border and also deep into some of the rural areas. I hope I did it.
Thank you so much, Dr. Castellano. There will be some time at the end for questions, but now we are going to be moving on to our next presenter. Our next presenter is Elia Chino. She is the CEO and Executive Director of Fundación Latinoamericana de Acción Social, FLAS Incorporated.
Well, thank you so much again, for the opportunity to be here. I'm blessed and have I really don't have the words to say thank you, And also I want to say thank you, Pacha, to select FLAS, one of the sites for visit. But I'm very happy to be here also to present about the work that FLAS has been doing in the Latino community for 30 years, because this year we are going to celebrate 30 years. My name is Elia Chino, the founder and executive director of FLAS. Well, early in the 90s, I stepped out after my best friends, they died from complications of HIV and AIDS. But also my siblings, they was dying in friend houses, in apartment houses, and the hospitals, but less with the family, because the stigma, the fear, the discrimination, the taboo, the misinformation in the Latino community about HIV and AIDS. And that's when I take an action. I say, I need to do something about it. And the first thing what I did, I remember AIDS Foundation Houston those years, and I said, I want to be a volunteer. And they give me the list where I can be a volunteer, and I choose to go to the Bentown Hospital, where 4 5th floor in 6. All the best was with people with full blood of AIDS dying. I had the opportunity to they share the last breath in my arms when they was dying from complications of AIDS. Now, you know what? They give me the strength to continue fighting until today. I don't know how many thousands of lives I've been able to save during all these 30 years. But also, it's not been easy, this work. I always ask myself, and I ask God, why you send me far, far away from Michoacan, Mexico, to over here and to do this work, the most difficult work in the world, because this has been my journal of my life. This has been my life. And I never lost my faith, because I just went up there and helped me with all my heart. And I never thought all the complications that I going through. I lost 2 times. I was fighting at my job because I was doing this kind of work. And that really put me in a position that I was angry, I was upset, but I was with more energies to continue fighting for justice, fighting for people that was dying. I can count with these fingers on my hand the people that survived from those years. Thousands and thousands and thousands of people died. But I can count it also with these fingers on my hands the people that are talking about on TV, on radio, I'm HIV positive and I can live with HIV because it's a medication. And it's the stigma. That's the problem, the stigma about that nobody wants talking about HIV. Since then, I've been working with all the organizations, the health department, universities. That's the ones that embrace me because I think they saw something on me that I want to do good for the humanity until now. FLA's mission and vision, we are committed to enhancing behavioral health and wellness services for the Latino community. Our vision is to create a positive impact in the Latino community for a better quality of life. As Pacha went yesterday to the main office, is there, and we have a good time, correct? Yeah. Thank you. Some of the programs that we have free HIV testing, HIV, hepatitis, syphilis, gonorrhea, chlamydia, and condom distribution. All these programs have been sponsored by CDC and City of Houston Health Department. Free counseling services from SANSA CSAP, Project ELIA, that provides mental health services and substance use disorders. Food pantry for people living with HIV and cancer. Because I'm a survivor of cancer, through all these years, all the stress, working so hard, the suffering and my pain, I developed cancer in 2017, and I was dying. I went through chemo radiation, but I'm here with a life to continue fighting. Education and prevention services, HIV awareness classes, linkage to care, behavioral health service to support our patients. We have a collaboration with the probation department to provide those services for people that are in probation. And also case management. We have housing through HOPWA, TIBRA. And the last year, we be helping 340 times for people to assist them with rental assistance. And we helping about 600 times to pay utilities. Youth Education Workshop Project reach out that we need to continue do outreach all over. We need to enter in apartment complexes wherever in the city. We need to go all over and provide education. And this project is sponsored by SANSA CSAP. Support groups and workshops for the LGBT community plus MSNs through the project Reconnect, Circular Growth. The FLAS Trans Center empowered the Latina women to be sustainable and to continue receive trainings for they can advocacy for themselves and the community. We had a window of health with the collaboration of the Consul General of Mexico. When we, in the last 4 years, we've been able to linkage to primary care service to 120,000 people. Through all these years, this is some of my staff. Through all these years, plus we've been able to provide to 750 Latinos about HIV information. We reach out 1.5 million people because the people from Univision, Telemundo, and radio stations, they know me since I started the organization. I've been established trust. I've been established a good relationship with them. We've been providing STDs education to more than 30,000, providing mental health services and substance use disorders for over 2,000, assisted with a gold card, tarjeta dorada, for over 4,000 people, distributed over 8 million of condoms, hosted 2,500 health fairs, provided testing for over 30,000 people, and provided referrals for social services such as primary care services, immigration, housing, domestic violence, marriage, emergency assistance, and other needs. We assisted over 3,000 people with rental assistance. And also, as I mentioned, with the great collaboration of the Mexican consulate, because FLAS was able to establish the window of health, we've been reaching thousands and thousands of people every year. FLAS is in this area, in zip code 77036, where the incidence of HIV is the highest in the city of Houston. The challenge that we have, poor public transportation, housing and to undocumented individuals, unemployment, funding, lack of health insurance, poor medical care for Spanish speakers, for the qualified health centers. We need more physicians, MPs that speak Spanish. Mistrust of the systems, scared of knowing their HIV status, no support for HIV community from the local officials. They need to get informed, they need to be educated about HIV, immigration issues, stigma and poor community support. Recommendations, more money, more funding. And I think that the agencies, whenever they apply for funding, I think they need to request on the RFPs for every 100,000 2 fully bilingual staff members. Provide funds to small agencies who need support to provide sustainable housing and food. Allocate funds for public transportation, for testing and follow-ups appointments, for primary care services and support services. Provide incentives to encourage people to get tested for HIV. Assessing healthcare services for everyone. Social determinants of health, that's the big one, okay? Under that one falls housing, education, primary care services. And I have it at least, it's all that immigration issues because we have a broken reform. And we're talking about community health workers, okay? We provide those trainings, but these people, they don't have the documentation to work. Where they want to work? Nowhere, you know? Health equity for underserved minority communities and HIV stigma and discrimination in the community and the workplace. Thank you.
Wow, very powerful. Thank you so much, Elia. You brought me to tears. Our next presenter, Mr. Pedro Coronado, is the Deputy Chief of Organizational Development and Training for Valley AIDS Council.
Hola, hello everyone. Good afternoon. Pedro Coronado, thank you so much for having me here today. Thank you for inviting me here representing not only the Valley AIDS Council, but also representing the entire Texas-Mexico border and making sure that, you know, voices are being heard. And as previously mentioned by Dr. Seeley, right, we're literally all over the place, right? If I go down all the way, I provided you all with like a little infographic with some information. It's also up on the screen. It might be too small to see up there. And there's some additional information out in the lobby. But we are everywhere, right? So as Mr. Chacon had mentioned, right, we do have the National LatinX Conference on HIV, Hep C, and SUD. We get people from all over the country, right? We get people that come from Alaska. There's one one person in particular that she always comes every single year. We've been hosting conferences for almost 25 years. And since then, they have been going to our conference from Alaska because they say there is a Latino community in Alaska. All right. So we are everywhere. Everybody wants their tacos. So yeah, well, come to the valley. So I will be using the term, Latinx. Just I want to be mindful of all of the people and all the genders that might be in this room or not in this room. So I will be using Latinx in regards to referring to Latina communities. So picture this, right? It's 2003. I broke up with my boyfriend. I'm 19 years old. And I asked my friend, where can I go get an HIV test, right? I walk into this place in downtown Brownsville, which is in Cameron County, one of the counties that is #1 in lack of health insurance and #1 in poverty. It's located under the hotel that rents you a room by the hour, and it was like $20 an hour at that time. And I saw a sign, right, that they're looking for a street outreach worker. I was a college student. I said, why not? Part-time. I did it. I applied. I was very persistent. After a while, I think they got tired of me asking for a job, and they just gave me a job. 21 years later, I'm still in that organization, which is the Valley AIDS Council. That same friend who gave me the phone number and the address to go, I was the person that actually gave him the diagnosis of HIV. Fast forward till now, second time where he's stage 3 HIV due to the social determinants of health, due to mental health, due to just everything you can think about, right? In between losing multiple friends to HIV, losing a friend right before PrEP was launched, which could have saved them, So the organization I work for, it's, people tell me, with all your experience, everything you've done, why don't you move to like New York, go to Chicago, go to LA, I'm like, why, right? Like they already have other Pedro Coronados over there working, right? They need the Pedro Coronado here. I'm going to stay here. I'm going to be here for my people, right? So the Valley AIDS Council, we do provide status neutral services. We are not an HE jurisdiction, but we do provide services like we are an EHE jurisdiction. Dr. Castellanos made a great point about, when we talk about the 4 pillars, they really don't work in so many ways for some of these areas. Maybe for Hidalgo County, for Cameron County, that are right next to each other where I'm from, to El Paso County in that area, maybe it might work for them. But when we're talking about Laredo, Webb County, Maverick County, which is where Uvalde and Eagle Pass is at, they're barely even just trying to do PrEP. They're not even doing rapid ART. They're not doing rapid PrEP. They're not doing so many things because they don't have the infrastructure. They don't have the funding. They don't have the capacity. There are medical deserts out there. People will get the training there, and then they leave, right? We have a medical school now in the Rio Grande Valley, UTRGV School of Medicine. But once people finish, they're gonna leave. They're gonna go somewhere else, right? So that's kind of what we're facing down there. When we look at the state of Texas-Mexico border in terms of HIV diagnosis, on the second image there you will see that in 2021 we had 314 new HIV diagnoses everywhere, all the way from Cameron County all the way north up to El Paso. If we were to drive up there and go through Big Bend, it'll take us approximately like 14 hours or so to get there from one end of the border to the other. If you compare this to the states of either just Oklahoma or Arkansas, we're right behind them. And those are states that are EHE jurisdictions. Working on the border and doing border work is very different than doing work in Houston, Texas. Very different from doing work in San Antonio and, in so many different parts of Texas, right? So, I just kind of wanted to provide that information so you can kind of see everything we're doing. If I have to do work through our South Central and Education training programs, and I have to do training in Eagle Pass, I have to be driving for 6 hours just to get there to provide the training. Why don't they get the training from San Antonio? It's only 2 hours away. It's a different population. Yes, we're all brown. We might, speak almost the same language, but at the end of the day, it's different, right? Because we're dealing with more people with, who have less access to health insurance and other services that are not being provided. We have checkpoints. Recently, I was doing a training in Baton Rouge, and actually even in Dallas too, just last week. And I talked about checkpoints on the border. And then people are like, they're looking at me like, what is a checkpoint? What do you mean by that, right? We're like, well, after we cross the river, and, then we have to cross another checkpoint in order for us to get past. So if you look at the map right there, you see the orange part. For the most part, right when you get to the green counties, that's where you're going to be finding all these checkpoints. So technically, it's legal profiling, right? So based on the way that you look, Border Patrol agents can ask you if you're a U.S. citizen or not, right? So we grew up, first thing, as soon as we get to the checkpoint, saying U.S. citizen. That's how you cross the checkpoint. If they don't believe you because of your accent or the color of your skin, or you just look suspicious, or you drive too nice of a car for a brown person, because you might be trafficking either humans or drugs, then they can ask you for your documentation to be here in the U.S. So that's what we have to deal with. Talking about the conference that we're having, we have so many advocates that cannot go to El Paso, Texas, because then they have to go through the checkpoint and they might get stopped. So as we respond to those kind of issues, right, we then have to think about the people in El Paso, Texas, who cannot go to, I don't know, we're going to have the conference in Las Vegas or wherever, right? They can't go over there because they have to go through a checkpoint as well. So some things to kind of really think about. Collaborations we've been working with other AATC, specifically with the Pacific AATC, is with a great team with Tom Donahoe, and we work with the UCLA AATC and also in Phoenix as well. There's this collaboration called UMBAS, and that's the U.S.-Mexico Border AATC steering team, and that in itself, Tom was spearheading these information sheets that any provider can utilize in case their patients are going to be going back to their home countries in Latin America. So these it took years to put these together, and it's all about what kind of health insurance is available for people with HIV. They return back to their home countries, what kind of medications are out there in terms of antiretroviral therapy, and then even to ICE has played a big role in my family, not in such a good way, right? But I will say this, right? There's times that we have to kind of build these bridges with some of these agencies, because if I have family that is family living with HIV and detained by ICE, I want to make sure that ICE is providing the best care they can for my family members there, right? What I believe and think, or whatever my thing is that I think about ICE, is a whole different thing, because I just want to make sure that people are taken care of. So, kind of shout out to Tom Donahoe that was able to kind of make those relationships happen, right? So those informational sheets were super helpful. We put together meetings with our counterparts in Mexico. We have to work with our Mexican counterparts, because there's no way for us to do the work that we do on the border without reaching out to them. Luckily, the ones that we tend to work with the most have visas that they can come over for meetings. And then obviously now with all this technology, we can have Zoom meetings, but we get to talk about what's going on, especially what's happening with our asylum seekers. I was so happy to find out that, recently, not just like in the big metropolitan areas in Mexico, like Mexico City, Monterrey, Puerto Vallarta, all those places, that they were doing PrEP. Now all these other border towns are doing PrEP, and they're providing it to asylum seekers. So now the job is that once the asylum seekers come over, or people migrating, or whoever it is, however they're coming over, that they continue with that, not only with preventative services, but also with preventative care, right? So when people are coming over here, the problem now is that they don't stay on the border. We might help them, but as soon as they get to wherever they need to get to, it'd be the Washington, D.C., the Carolinas, Florida, wherever they're, Alaska, wherever they're going, right? We need to make sure that they're being connected to the right services and the organizations. I'm not going to call out the organization in Utah, but there was an organization that was trying to be very helpful with us. They found the one person that speaks Spanish in their organization to help one of their clients, and then that person got taken away from another organization. And the client that I've been trying to connect, it took them at least a good 8 months to get into HIV care. You know what I mean? We're talking about, detectable viral loads as well there. So community viral load goes up, especially within our Latinx communities. So the last thing I'll say, when it comes to building up the workforce, and thank you so much for also bringing that up, Dr. Castellanos, right, that community health workers, I'm a community health worker instructor. I've been an instructor for the past, 4 years, 6 years as a community health worker. That is, I feel personally, that's the key to be able to infiltrate, to get into our Latinx communities. They're the ones that know the communities. They're the ones that are going to be able to help us defeat stigma. If we are able to hire people, right, regardless of status, we're able to hire people, however it is that we pay them, right, to be able to go into these communities and talk about HIV prevention, sexual health, women talking to their daughters about sexual health and being sexually liberated, as the women prior to this talk that we're talking about, right? Going into spaces that typically we don't get to go to. I think that is super important. The workforce, we need to do more for our workforce. It's ever changing. And, you'll find more information on this sheet that I gave you all. And I guess in Q&A, if you have any questions, I'll answer those. Thank you.
Thank you so much, Pedro. That was amazing information. Next on our agenda, we have Stephen Vargas, and Stephen is an advocate of the community. Thank you so much for being with us today, Stephen.
Absolutely. Thank y'all. Thank y'all. It's good to get nice warm receptions in my hometown and in the state as well. In my hometown, I know I'm loved. Sometimes when I go to Austin, I don't feel so loved. But, we do the good work, right? And so it's about, what did someone tell me the other day? The good trouble? Yeah. It's all in good faith to make things better for everyone else. And we will challenge you when we see that it's not being done. And no one is immune from that challenge. And so my name is Stephen Vargas. I am a person living with HIV now 29 years, which is over half my life. I've been helping people with HIV since about 1988, 89, documented 89, helping my parents, my mother, my stepfather who had HIV. They passed away in 94 and 95, the year before we had the emergency approval of ARVs for folks. I found out about my own HIV diagnosis in 95, before my mother passed away. And so I had that same idea that my life trajectory was going to be just like theirs, and some of their friends that I was helping access care back in those days, the care that we had, minimal that it was. So I just thought my life was going to be the same way as theirs. I didn't think I was going to live to be, do I say my age? Yeah, I'll say my age, 56. I didn't think I'd live at 27. I didn't know I'd be here. Yeah. So, and lots have changed. My entire life has been affected by HIV. In my freshman year of high school in 1983, we already knew about HIV. I went to the high school for performing and visual arts. They told me to say it like this. I went to Beyonce's school. Yeah, that's right. And so before she got there, yeah. And so we made it desirable for her to want to go there. But when I was there, there were gay kids, there were gay teachers. We all knew who was who. No one hid. It was very open. I had my first boyfriend as a freshman in high school. My family was very supportive. And so that kind of environment really instilled a lot of confidence in me, for one thing. It also instilled a lot of resilience. When I started seeing them and their friends start passing away because we had no real effective treatment for HIV back in those days. I talk to survivors today, people I see who would have been my mother's age. My mother would be their age today if she'd survived. And sometimes I wonder, in the state of Texas, which is, it doesn't do great when it comes to the for its fellow Texans. And it's just going to be, mine is more, it's a shout, it's an alarm. I'm sounding an alarm. As a person with HIV in Texas, who has worked as the HIV workforce for at least 15 years and see what it's like there, and done things at the national level with Latino Commission on AIDS, the ARB Guidelines Panel. I'm telling you right now, everything you've heard, it's worse than it even sounds here in this state. I am sounding an alarm, federal partners, that we need you here because we cannot count on our state to give us the accurate information that we need to end the epidemic. In fact, they're doing things that counter our efforts to even ending the epidemic. The first national HIV/AIDS strategy vision in the United States, HIV cases would be rare, and when they do occur, every person, regardless of race, ethnicity, sexual orientation, gender identification, or socioeconomic circumstance, would have unfettered access to life-extending care, high-quality life-extending care. But let's not forget how it ends. It ended with free from stigma and discrimination. We haven't gotten there. We're going backwards in this state. We are going backwards, and it's a testament in the laws that they're making that prevent people from caring for the kids the way they see best if they're of trans experience, and not just them, the adults. That's a stigmatizing environment. Federal government, this is a call right now. We need your help. When we have Latinos being stopped at borders because they look Latino, and some that don't even. My brother's black. They went to go visit his wife. Outside of half our family's black. They went down to visit my niece and her husband, a police officer in Corpus Christi. On their way back from Corpus Christi, the checkpoint, they pulled them over, and my sister-in-law Jeanette says, "Ron, why are they pulling us over?" He said, "Well, you're a Vargas now. They'll be pulling us over." And so Vargas is a Spanish surname, and so even though we look black, they're going to pull us over. Yeah, and those things do happen here. We don't have people offering people water crossing this state. We have people stopping them at the border with those checkpoints, and not just there, women's health care. We have checkpoints to find if people are trying to leave the state to get their reproductive health care. Checkpoints to see if they're doing that. I'm sounding alarm, federal government. Okay, those are the things that really affect us here in Texas. I get tempted to leave sometimes too, but like Pedro, I feel that urge to just get out of here. But then I can't help but think about everyone else that's here doing that good fight, and that's what keeps me here. It's what keeps me here. We still have a lot of work to do. The syndemics, the epidemics. When we talk about syndemics and epidemics, I know syndemics refer to a malady, an infirmity. We need to throw poverty in there as part of that syndemic. It's what helps propel and keep it going. So if we don't have poverty as part of those acquired diseases or anything, then we're not really going to address the syndemic. All you're going to do is, again, address the medical situation and not address the situations that got us there. So we need to include poverty when we talk about the syndemic. And if we don't, I'm not going to take you seriously. That's basically it. The administrative work. When I worked as part of the HIV workforce, my bosses are still here, at least a couple of them are. They'll tell you, I hate the documentation. Nothing kills the spirit of helping than the kind of documentation you have to do. Hear me again. We need people to be out there doing what they do best, which is caring, being compassionate. And what kills that spirit is the amount of documentation they got to do. Federal partners, we need something to be done about that. Y'all did do something about that back when, and put a whole bunch of money into it when it came to the developing electronic medical records. CDC put a lot of money in that and got a lot of hospitals, some systems to get their electronic medical records going. That's only half the job now. We need money to help those electronic medical records to be talking to each other. We need that investment. We need that investment because only half the job was done, and we want to complete the job. So that investment to get the electronic systems to be able to talk with each other so we can more easily keep people in care. What I loved about Elia's list of the staff that she had up there on that screen, I counted the number of folks that I've facilitated Project LEAP with, and half that staff, more than half that staff, were folks that have gone through Project LEAP. I share that Project LEAP is a 17-week training that we do here that's part of HIV empowerment and helping people that want to become planning council members, get them ready for that. So not too surprised when you get to sit at the table and have to make decisions about tax dollars. with that, when I saw that half that staff, it's no surprise that they have people living with HIV centered at the work that they do. Half of them have got some information and training about showing them exactly why that's necessary. So it's not a surprise, and I love seeing that. The city funds, I'm going to go there, Marlene. So I'll say it here. Our city puts not a single dime into HIV services. I have gone to 2 different mayors, both of them I like, and asked them to create a line item in their city budget to address HIV concerns. The first time I did it, it looked like they were doing something. All they really did was request more money from the CDC or more money from HRSA, with the same rules that CDC has and that HRSA has. The same holes that were created because they create those holes. We had nothing to fill those holes because you're using the same money with those same holes. That's why we need a city line item budget in our coffers so we can fill those holes that CDC doesn't allow us to and that HRSA doesn't allow us to. That's why we need that money. So we're going to be doing it again with the new mayor. We give him some time to get himself settled and move things around like he's doing. But then we're going to go again. I'm saying this now, so folks get ready. Every HIV Observance Day, that week for public comment, whatever it is we're observing, that group of people will be right in front of City Council to let them know that we need a line item in our city budget to address HIV concerns. For the October 15th week, Latinos will be there. Yeah. Okay. Yes. And long-term survivors, those of us that are still here, I'll talk a little bit about that. We'll be there for that. Long-term survivors, a little bit about that. Just to highlight the discrepancy and why we need federal help and intervention, I say, is when I look at the national average of people, the prevalence of people that are considered long-term survivors, according to that original definition that came out, people that were diagnosed with HIV prior to 1996 or 95 or before, nationally that average, and in Houston, it's about 25%. About 25% of us make up the entire prevalence of HIV. That's how many of us are still here from those early days, 25%. You want to know what it is for Texas? 10%. That shows you, that demonstrates the lack of quality of care, nowhere near enough to help us stay alive to reach and see these days. That's the state of quality care of Texas when it comes to HIV. So I'll try to keep it short, I guess. You know, thank you. I thought I saw that. Kimmy asked me, a person who works at FLOSS, if I could give her a list of doctors or physicians, nurses even, nurse practitioners that speak Spanish, because we don't have enough. And Latinos wait a much longer time when it comes to getting into care, getting to service, and getting out those doors, because we're always waiting for that one translator. So thank you, Elia. Federal partners, hear what she said. For every what, 100, what? What was it? 100 bilingual. Yeah. Make sure that that's in the RFPs to ensure that we have enough Spanish-speaking doctors so that Latinos do not have to wait as long. That has to be in the RFPs. We have not expanded Medicaid like about 9 other states now, or 8 other states now. I think Florida's getting close, I hope. And yeah, then you should be proud of Florida for sure. It's our dying shame that we can't do that. The ballot measures, we can't even bring it up as a ballot measure in this state. They took that right away from us. We can't even do that. So again, federal partners, we need an intervention. We need your help. When we talk about mistrust, just a little bit here on this one, mistrust, because this is serious and important. There is a lot of mistrust, historical mistrust, we know, and we know the reasons. It's not just Tuskegee, it goes further back than that. Our whole maternal care, what we do with obstetrics, is built on the backs of African women brought to this country. And yet we see the worst health outcomes, maternal health outcomes for our African-American women in Texas and Latino women. And yet the entire system is built on what they learned off of their backs. Something needs to be done about that. At the national level, I say we need to rely on our federal partners because we cannot rely on our state government right now. But it's disappointing in a way that we have to rely on the federal partners too, because they've disappointed us too. As a person with HIV, we have said over and over again for a number of years now that we need to have discussions about how MHS is going. We need to have some serious discussions about the implementation of MHS here. It's really not working out. When you look at what's going on in Texas with Latinos when it comes to SB4, with women in general, with what we're doing to women's health, with the laws, when you think about the folks of trans experience, the LGBT community, this is not the environment to do something like MHS. So I need you to hear me. When I say, and I love fanfare, I love God. When I say that when we say now we call for a moratorium, it's that for years we've been wanting to have these conversations so we can really hash this out. It hasn't happened. When we ask simple things like just add it into consent, we're getting to saying, oh, we really don't have to do that. There's a rule that says, and they sent me that rule, and I know what it says. It doesn't mean it's right. Just because you have it as a rule or a law doesn't mean it's right. Is it right for SB4 to allow officers to stop any Latino and ask them for their papers? Is it right to deny women the care that they need for their health care and the longevity of their life? These are laws now. They're not right. And just because you have a rule that says that, oh, we don't have to update our consent forms because there's a rule that says we don't have to, it doesn't mean it's right. When situations change, then we need to add that change so we can see if people are still willing to give their consent. The situation changed. You're using our genetic material for other stuff and that we didn't know about, and we'd like to have a discussion about that. The discussion time for that now is gone. Now we need a moratorium. That's what we need. If we want to start building back trust, one of the quickest and easiest ways that that can happen among the community of people living with HIV is putting a moratorium on MHS. Are you willing to do it? That's the thing that needs to happen. Thank you. I'm done.
Thank you, Steven. Thank you, Pedro. Thank you, Elia, and thank you, Dr. Castellanos. Dear PACHA members, like to open for question, one request, brief to the point questions, and I will ask my panelists to please to do a short answer. Natalie.
There we go. Thank you so much to the panelists. I'm really glad we opened with this concept of transnationalism and the fact that it's back and forth, whether it's on their own will or it's by force. And so my question is related to that. Quite a few years ago, there was a collaboration with the Pacific AIDS Education Training Center in Tamdanaho, where San Diego was able to have a binational conference where we were able to address the local border states on both sides of the border, the federal government, to share the impact of immigration, deportation, ICE raid, and detention. And so a question is for both us as PACHA, and to the members on the panel, what would it take to have PACHA or partners to support a binational conference to see and discuss the changes in populations immigrating and migrating to the U.S. And to take a deep dive as to what those communities need? And so when a lot of times we talk about the LatinX, we lump in just everybody, but also to address that there's an increase in Haitian, Honduras, Guatemala, Colombian, Russian, and Venezuelans. And what we're seeing in the border in San Diego is the need to develop and create materials related to HIV in the Creole language. And so for us is the question of what would it take to get a binational conference? And then the question for Pedro is, what is the National LatinX HIV Conference doing in collaboration with UMBAS to talk about current binational issues?
Yes, so this year we are collaborating with UMBAS at the National LatinX Conference to have those conversations, and we're actually inviting to me, the most important people in my life when it comes to binational work is Dr. Carlos Alberto Carrillo out of Tamaulipas with the Capacites there on the border, and Natalie Gras, she is in Mexico City, La Condesa, and she luckily her mother's French, she speaks French, so she's the only person there, and that's one of the largest. It's kind of like the Ryan White program, right, in Mexico City and Mexico in general, where she's able to be the one to do a to provide that translation services for people that are coming from Haiti, right? Or anybody who speaks the French language. So we're inviting them over. We're inviting all of the partners, anybody who's going to be there. We want you to be in that listening session and to be able to ask questions of what needs to happen, what is happening there. Having conversations with Natalie, her telling me, hey, we have a big group of people from Venezuela, and we see Grindr popping up with, people selling sexual services for them in order to get food in their stomachs, right? Or have a place to live until they get to wherever they need to get to. I think that is something to really look into and to have those conversations, because, so many times that I hear that somebody who migrated over here, they're like, I didn't come with HIV over here. I got HIV in the US, right? So those conversations are going to happen there. Yes, it would be very helpful to not just to have it at this national conference, but to have these conferences happening, these binational meetings happening, and not only in San Diego with Tijuana, but also with, the Texas borders with their counterparts, and same thing with Arizona and New Mexico. We get very creative with our funding. I will say that, right? Because we have to when it comes to binational work, although it's very exhausting and it's very time consuming, and it could be a lot easier if we had our federal partners to be able to champion this to make it work. So
I will, Pacha, as a co-facilitator, I will table that question that Natalie asked for a subcommittee discussion, because that's an internal process in order for us to look into a couple of recommendations. Any other question to our panelists? Oh, Marlene, sorry.
I am sitting here completely full. I have to really thank all of my friends and colleagues on the panel. And to Stephen Vargas, thank you for sounding the alarm. When I hear him, Pedro, Elia, when they speak with such passion. But what I hope Pacha takes away is the authenticity of what they see and experience every day, that they are imploring us for help. I get tempted to leave sometimes too. I stay in this seat, however, because of you. I don't know if it was mentioned earlier. I unfortunately missed the first half of this panel, but immigration enforcement is a tangible, biting, violent thing every day. Immigration enforcement in Houston is the second highest in the country. Second highest to who? Dallas. When we say that we don't need more enforcement, we don't need more detention centers, we need more welcoming centers. If we simply put resources in the right ways, Stephen, the ethical ways, what we are experiencing in Texas, I know for many of you, it just feels unheard of. These things would be considered absolutely illegal, let alone unethical in other parts of our country. But here we sit in the state of Texas, in the United States. Last comment in a question to the group, somebody asked carrots versus sticks. And I'm screaming inside, going, carrots, carrots, carrots. What we need is a level of support. And maybe it was you, Tori, who said it this morning about the way we look at health equity really centers around the approaches that are needed in spaces like this. Funding has to look different. Grant making has to look different. Approaches have to be different. They have to be flexible and diverse for those of us who know what to do, who want to do, to actually be able to do. My question to the panel, please let us not leave the room today with anything left unsaid. If you would implore us as PACHA, as colleagues in other states and policy tables around the country, what would you implore us to do? And vice versa, what would you implore our federal colleagues, our funders, our grant makers at other levels to do? I just don't want to miss the opportunity. You've said a lot, you said it all. But is there anything we've left unsaid on the table? Please say so.
You spoke about flexibility of funding and the need to change grant making. And I think some things that can change how funding is distributed, not only in Texas, but across, as I said before, the low countries and other parts. How we look at the minority AIDS initiative funding, how we use the money that we have in Ryan White to support the work of community-based organizations and support the work that we on the ground are doing. If we want to address endemics, we need to enhance the workforce on the ground. They are the ones who can address the mistrust because they are part of the community. So that funding has to change. And how we look at workforce development, we cannot be people of color who are like in the hospitality service, basically bringing clients to a hospital. We need to have the tools to provide services ourselves as well. And I think oftentimes a lot of the grants go to places that the community doesn't trust to start with. So we need to look at issues like minority AIDS initiative funding, how we do Ryan White distribution of funding, what goes to biomedical interventions, what goes to treatment, how much is spent in prevention and early interventions, support for HIV and aging services. I think we can take a look at how that funding is distributed and balance that in terms of supporting the work at the ground. I just want to finish something by quoting. I want to quote something that I wrote down early on that Dr. Guillermo Ramos said. I think we have focused a lot on the shortcomings, but I want to highlight something that he said, the clarity and purpose and commitment of the work at the local level is evident. And I think that's the part that we need to say. We are doing what we can, and it's amazing.
Medicaid expansion is something we need help with. A few years ago, when we went to the state and urged them to do that, there were folks that work for our own Texas Department of State Health Services. I don't even think there's a single person here from our own Department of State Health Services. We need to thank you so much. Great. And the folks that are online, please be brave enough to put your names in the chat because we need you to hear this. With our own Department of State Health Services, when it comes to Medicaid expansion, I am part of our Texas HIV Medication Advisory Board. And one of the things we mentioned is to help use our ADAP funds to purchase, particularly for folks that are aging with HIV, health insurance. And they did propose that. And we made that recommendation as, ADAP does what it can do. It goes up the chain, and it was not allowed by our Health and Human Services Commissioner. So we have not done that. What I think the federal government needs to do to help all the states that have not expanded Medicaid is to mandate that those ADAP funds in those states that did not expand Medicaid must use ADAP funds to purchase insurance, particularly for those that are aging with HIV, all of us. That's one thing I'll say. Yeah, at least that. And the reason I say at least that, everything's piecemeal here in Texas. We just expanded Medicaid access for a whole year for women that are pregnant that are cutting off once they have their baby, which is great, but we know we need it for months longer than that. So we have that as an example, ADAP forcing that to happen for people living with HIV. There's 2 examples in which it was done then here in this state. We can build on that for the rest of the Texans.
Welcome. Elia? I just want to mention about the trans community. our trans community are living in poverty because they don't have the opportunities for work. But also they live in Texas, to New York, to California for apply for their documentation to legalize in the United States. But also they think, and we need to take it out this, that they being used for projects, for research, for testing, to give in $10, $20. And they are tired of the situation because they living on the streets. They living without housing, with food. And I think it's something that we have to thinking about it, that we need to support the marginalized, the most marginalized community in the world, the trans community. And I'm talking right now about the trans Latinas in Houston. Thank you.
Okay, let's go to DeAndre, and then Marvel, and then Paul, and then we're gonna close it up.
Yeah, I just kind of want to piggyback off what Ms. Marlene said too, and just say thank you all for your bravery to speak up today. I know it takes a lot, and the honesty, and just to know that we do hear you all here on this advisory board. And I also want to tell my colleagues a little bit more about like the political landscape, because you all mentioned something about women's rights here in Texas, and just so you guys kind of have an understanding of how much under attack those rights are, our trans rights are, and just immigration. Is that Texas? There's a few things that Texans, especially Republicans, do believe in. That's their guns and their bounties. The state of Texas has bounties put out for people who assist women with going and getting an abortion outside of this state. So if a woman goes to get an abortion, she won't be penalized, she won't be criminalized. But as a civilian, a private citizen can come. If I go help a woman to get an abortion, you can sue me for $10,000 and be awarded. Same thing for a complete stranger doesn't know me. But if you found out or you heard through the grapevine that I took a woman to go help her to get access to an abortion and so on and so forth, the state of Texas will allow you to come in and sue us. And I can be criminalized up to a felony for these actions. Same thing for immigrations. State legislatures have tried to put out bounties for people to report immigrations or what they would consider illegal immigrants in this state to be reported to the state or to ICE, so that they can get a bounty for that as well. And they've also tried to push where if drag queens are performing in front of minors or adolescents, you can sue that person as well for up to $5,000. So there's so many attacks, and the state of Texas continues to try to reward people for reporting these what they would consider crimes when people are just trying to live and be themselves here in the state of Texas. And so I do want to say thank you for pointing those things out to us and for raising the awareness. And I do think, and I believe that there's so much more that we can do. And I think that we will be more intentional in taking the recommendations that you all have put out there and taking it back to the advisory, to our colleagues at the higher level to make sure that they hear the needs and the ask of what we're asking for here in Texas.
Thank you, DeAndre. Marvel?
Yes, thank you for this panel. I chair the HIV criminalization and discrimination work group, and I'm curious about HIV criminalization, immigration, being undocumented. How has that influenced getting into care, linkage to care, and staying in care?
So recently, we, as SB4 was, everything that's going on with SB4, we've been scrambling to try to figure out what are ways that we can get in trouble and what are ways that we can be able to figure out how to not get in trouble, right, with some of these laws. So as we're providing transportation to people to get access care, as we're, whatever we're trying to link them into care, whatever the case may be, right, if we're working with asylum seekers, whatever it may be. So I think that's something that, we're always trying to have to figure out, and we never have too much clarity because things keep changing all the time, right, for us. And so that is a big concern for us, especially on the Texas-Mexico border.
Thank you. Yep, brief.
I believe right now there are 29 states that have some type of legal criminalization related to HIV. And in most of the states, there are very few cases that have been prosecuted, but the message has been sent. Because it's not so much sometimes about the number of cases that are going to be penalized, but how the message is sent about what's normal and what's not, what's allowed and what's not. And we have an epidemic that has a lot of Black and brown people, so the message has been sent. I think it's important to look at the issue of the criminalization within the larger social context of inequality and discrimination.
Thank you. Kawata, last one.
Once again, the old guy gets to speak last and say a couple of things. First of all, I just want to tell you, being able to visit your agency was an extraordinary honor. I hope you know that I've known you for years, but to see the work and to see what you have accomplished, it brought me great joy. It brought me great joy because I worry about Texas a lot. I worry about what's in front of you. And so I couldn't let this moment go by without saying thank you. Without saying thank you for what you do for so many communities, and not just the Latino community, but also the transgender community, also people living with HIV, and also Texans. And so it was a privilege to go and visit what you do. Pedro, I want you to know how important I know your meeting is. My staff, every year, we have to put it in our budget. We have to put it in our budget. No, we have to put it in our budget. And so I want you to know that you're making a huge difference. That the ability to particularly talk about some of these border issues are so impossibly difficult. I learned something from you. I did not realize that beyond the border, in that green zone, that they were still stopping people. That is fucking ridiculous. And it, I both appreciate knowing that and am terrorized with that knowledge. What is this America that we're living in? What is this country that we're living in right now that has a border within a border? I mean, because that's basically what it is. It's a border within a border, and it's wrong. And so thank you. I know that the fight is not easy, and I know that you have so much in front of you. And I guess I want to close by talking to our federal partners who are here. We got a lot of federal partners here, and I hope they heard you. I hope they heard you. This is the challenge, and I'm going to say this to our federal partners as bluntly as I can. I know you're our friends. I absolutely know. I have no doubt in my world that Kay is our friend. I have no doubt in our world that CDC and HRSA are our friends. There's not a doubt in my world that you live in a structure that prevents you from doing things. And now I need to say to you, I need you to fight harder. I need you to fight like you've never fought in your entire life, because we're about to face a moment in the history of our country that we've never, ever faced. This November, if there was ever a moment for us to be afraid, to be really, really, really afraid, it's November. And I worry so much about what we need to get in place before that election. What we need to get in place as leaders. And what I want you to know is, publicly, I'm going to criticize the shit out of you. Privately, I'm going to support you. That's my job. My job is to stand up and say, we got to do better. We got to make this better, because it's just not okay. It's just not okay what is happening here. And so please know that I'm going to continue to criticize the federal response while I try to support you, because I know you're our friends. And I think that's always the challenge that we have to face in these dialogues, which is, how do we criticize our friends and ask them to do better? When President Biden was first elected, on day one, he proposed to look at the structural racism that is built within federal contracting. I thought that was brilliant. I thought that was, I started to cry. I was like, here is someone who understands that the process itself is racist. And so if the process itself is racist, how can it ever touch the communities that we need to reach? And that's where I need your help. because you have the ability to do three things that I don't have. Number one is that you write the RFPs. And you write the RFPs. And so as you are writing these RFPs, and please excuse me when I say it this way, but I'm going to say it this way. So often they go to Beltway bandits. So often they go to hospitals. So often they go to people who do not have the real connection to community. And that until we can be a part of that development, we're going to get the same result. Number two, you get to choose who evaluates. You get to choose who reviews those responses. You get to choose how they're going to look at those responses. And the truth about it is that if you choose people who only support the existing infrastructure, you are, oh, sorry. Yeah, okay, so we're going to start again. No. But you get to choose who does those reviews. And the truth about it is that the reviewers are as critical as the proposals themselves, because the reviewers can reflect the values of community and not just the values of the federal government. And so those reviewers are going to be critical and essential. And then the final piece, and we saw it when we went yesterday to one of the agencies. They need help. You make it impossible for them to win. You make it impossible for small organizations that don't have the financial infrastructure to be able to effectively compete against this. And so we need to figure out, how do we level this playing field? And part of it is that until we can level the playing field by really building the infrastructure that you need to respond to a government contract, we're never going to be able to lift up those agencies that we need to lift up. And so just let me say one quick thing. Mm-hmm. I know you're our friend. I absolutely know you're our friend. Now I need you to fight for us.
Thank you. Thank you, everyone.
Thank you, Paul.
Thank you, Paul. I just wanna remind all of us that, I echo, the points that we discussed in this section. I wanna say thank you to the panelists. Our federal partners are committed. I think it's intentional for us, for PACHA to be in Texas. And I think it's intentional for, as a PACHA, to take all the feedback that we have been debating, not only in this section, but throughout the site visit that we did yesterday, throughout the meeting today, and take it back to our subcommittees and be action-driven. Why? Because, as Stephen said, he is really challenging us to do something, because, as Paul just also mentioned, we need to change many things. And I wanna really, again, thank you to everyone that is here, through the digital and virtual space, because it's about all of us. And the only way that we're gonna move forward is we honor our partners, honor the communities that we serve, and advance the strategic plans that we have in front of us. Thank you very much. Let me ask for a round of applause to our panelists. And then I pass on behalf of Duvia and myself, say thank you, and pass it to our PACHA co-chairs.
So thank you very much, Guillermo and Duvia. Just a round of applause for the two of you for organizing this wonderful panel. So thank you, Duvia. Thank you, Guillermo. And thank you to the panel. So there is another comment from Kay, and then Kay, I'll wrap up after you. Okay.
Great, thank you. I want to say an incredible panel, and thank you, Paul, for your comment. If you know anything about me, I'm a bottom line girl, and I often ask the question, so what? My team knows that, so what? So what I look for, and what I know the advisory committee members, we've heard the conversation, we've heard the alarm, but the advisory committee members, that's the specific things and recommendations. So we have the narrative, we've had the discussion. So those are the very things. And Paul, you listed 3 things. So those are the kind of things that as you go back into your work groups and your subcommittees and you start talking about recommendations, that's where when you put together whatever it is, because you guys decide as the advisory committee members, is it a letter? Is it a resolution? Whatever it is, because that's your decision as the advisory body, but be very specific on what those things are, not the narrative is great. It has been established and we've heard it and it's compelling. And thank you for that alarm. But that is the beginning. Now it's the so what and what that looks like as you build into those very, very strategic recommendations. I heard Dr. Wheeler pushing earlier, and I was like, yes, because he was drilling at get specific. What is it? What is the it? How do we move this forward? What are you asking us to do? Us being the advisory committee. So that is just my pitch to the advisory committee members. When you go back into your subcommittees and what you've heard today, then you take it to the step further and move on.
So, Kay, thank you very much for that. I think it's a great reminder. I'm just going to reinforce it, something that Marlene and I were talking about in preparation for Friday, that really the work is in the subcommittees and thinking through what are the specific recommendations and actions that we're going to take as a committee. And so, again, I really appreciate Kay, you reminding us of that. Just one final comment. So, Guillermo Dubia, we said thank you, but I want to, again, just acknowledge the terrific work. It's such an honor and a pleasure to see the conversation over the last day in our site visits yesterday, but in particular for me as a Latino gay man, it's wonderful to see a focus on the Latino community. So thank you, all of you, for being here today. We started off by really emphasizing the diversity of our community. It is true. We have U.S. born, we have foreign born, we have folks that have been here for many, many years undocumented that are long-term residents of the country, as well as recent arrivals. We've talked a lot about our differences, but I want to end by saying that we are one Latino Hispanic community and that the way forward is by us coming together and really leveraging our power. We are the largest ethnic racial group in the nation. We are growing because fertility and migration, and we are the future of the United States. And the region is what we need to focus on if we're going to sustain what we enjoy so much in our country. So thank you very much. We'll be back at 5:15. And we'll have some public comment. Thank you.
Produced by the U.S. Department of Health and Human Services.